everybody, and thank you for joining Duke Science and Society for the latest installment of our Coronavirus Conversation series. My name is Sarah RISPIN-SEDLAK, and I'm a senior fellow at Duke Science and Society, where I work on organizing these talks. Also, be sure to head over to the Duke Science and Society website to look for our future coronavirus conversations. Right now, we have in planning stages a talk on wearables and the ethics and some of their use for early COVID detection, and the policy and ethics of using human challenge trials for finding coronavirus treatments and vaccines. While you are there, you can also learn about our master's program, where our students and faculty address the issues we've discussed in the past few weeks during these conversations on a daily basis. With that out of the way, let's meet our moderator and guests. Dr. NITA FARAHANY is a leading scholar on the ethical, legal, and social implications of emerging technologies and science. She's a professor of law and philosophy, the founding director of our program, the chair of the Duke MA in Bioethics and Science Policy, and a principal investigator of SLAB Lab at Duke. She is also the co-editor-in-chief and founder of the Journal of Law and the Biosciences. Rachel DRAELOS is a Duke MD PH.D. candidate in the Duke Medical Scientist Training Program and a researcher in Dr. Lawrence Caron's lab. She focuses on developing novel deep learning methods for clinical use and has recently written a paper, now in preprint, on machine learning for abnormality prediction for large-scale chest CTs. Dr. Timothy DUNN is a postdoctoral associate in the Duke Department of Statistical Science and a Duke Forge scholar. He specializes in deep convolutional neural networks, researching how to use neural networks for predictive modeling in healthcare, including functional brain imaging. And finally, Dr. Raymond Geis is a senior scientist with the American College of Radiology's Data Science Institute and a fellow with the Society for Imaging Informatics. Importantly, he is a lead author of the October 2019 Multi-Society Joint Statement on Ethical AI in Radiology. NITA?
Thank you, Sarah. It's a pleasure to be here with all of you today, and thank you to our panelists for being willing to join us and talk about these important issues, particularly during a global pandemic and with applications for the global pandemic. I think the way that we're going to do our conversation today is that we'll hear first from Dr. DRAELOS, then from Dr. Dunn, and then from Dr. Geis, who will give opening remarks for about 5 minutes each. From there, we will move into a conversation amongst the four of us to talk about some of the social and ethical and legal issues with respect to AI and radiology, focusing in part on the pandemic and more broadly to be able to give us the best information to understand this relationship. The hope for this conversation, along with every conversation that we have at Science and Society and as part of our coronavirus conversations, is to make sure that we have a firm understanding of the facts and the science in partnership with the ethical, legal, and social implications. And so my hope is that we'll start with some of the establishment of the facts and move into a broader discussion. With that, I'll turn it over to Dr. DRAELOS to kick us off and ask that she give us her beginning remarks before we dive into a deeper conversation.
Thank you very much. I'm looking forward to being on this panel today, and I'm excited for the opportunity to participate.
It looks like we're having a little bit of technical difficulty, so let me turn to Tim for his opening remarks, and we'll come back to Rachel in just.
Hi, everyone. I'm excited to be here today. Can you hear me? Okay, great. I'm going to use my 5 minutes to touch on general problems and pitfalls with AI model validation. And AI is in this exciting phase where we've generated a lot of promising sort of proof of principle results on highly curated academic data sets. But taking these methods and then applying them in the real world requires very careful attention to detail. And ideally, I think new sets of standards for validation. Hopefully we can touch on that today in our conversation. Because in its current form, it's sort of a new science. Of course, they're sort of old techniques reimagined. But because of that, it's not always clear what to do, and it's easy to take shortcuts spurred on by impressive preliminary results, right? And really wanting to get these into the clinic as fast as possible. But if you don't properly validate them, they might not work as well when they get to the clinic in the real world application phase. We have, of course, some general general best practices for validation, but it's becoming increasingly important that these are more formalized and regulated, and that these regulations might need to be domain specific. So to illustrate this, I'll tell a story about a colleague who was working on a system for detecting birdshot chorioretinopathy. This is an autoimmune disease that, if left untreated, can lead to blindness. And birdshot has some fairly obvious visual signatures if you look in at the retina and take pictures of the retina. And so it's one of these diseases that seems like a prime candidate for AI diagnosis, right? So you want to go and you want to get screened, right? But maybe you can help ophthalmologists make these screening decisions by training one of these algorithms to help you with diagnosis. So one day, my colleague came to me and asked for help interpreting his network's performance. His network that he trained on a data set of positive birdshot images and negative healthy controls was getting close to 100% diagnostic accuracy on the test set, right? So if you're unfamiliar with the test set, a typical way to do validation for these models is that you have a data set they're using to train these algorithms, and then a held out test set that's supposed to be estimating the real world performance, because the model hasn't seen that test data during training, right? So it's not supposed to have bias on this test set. So it's supposed to be a good estimate. And he was getting close to 100% accuracy on this test set. You should always be suspicious if you're getting close to 100% accuracy, and he was, and so he came to me for help. And so what was the problem? I reviewed his analysis plan and code, and everything was by the book. But once we started to review his images by hand, we figured out the problem. For some reason, nearly all of the positive birdshot images in the training and testing set were slightly different than the controls in terms of cropping. So not in terms of real image features, right, that corresponded to birdshot, but the birdshot images, because they had come from a clinic of specialists, had been processed differently than the images they were using for controls, which came from a general Duke EHR database. So what that means is that the neural network that was training on these images learned to just use this cropping artifact as a signal for the disease, and not actually real image signatures for this disease, which of course is not going to transfer very well to the real world, of course, when these images are different. So this is a fairly insidious bug, right? Because he was doing sort of all the things you need to do, right? Have a good training set, a testing set, right? But obviously this would have failed in the real world. And so how can we try to address these issues and find these problems right before they actually get approved and make it into the clinic? And there's several places in sort of the full clinical AI stack where you can do different types of validations. For example, a best practice here at Duke is once a model has been built and trained, you actually get it into Maestro Care, right? So you get it in the place in the care pathway where it will actually be run if it ever makes it to market, and then you run it in silent mode for a time, right? Where all it's doing is making predictions, right? But in a way that's utilizing the full pathway, right? So there's ideally, probably very unlikely these types of artifacts that could arise, because it's using the real data as it would see it once it was in the clinic. So doing that for this birdshot example, of course, because these images of controls in birdshot would not be processed differently. Once this method was in the full pipeline in silent mode, the model would have failed and you would have known, right, that something was up. Before we even get to silent mode, you can also, of course, get a sense of problems in your data by being very careful about inspecting your data distributions, right, and properties of your images, basically being a rigorous data steward, right, before you get to training your model. Remember that your test set is only good for estimating the accuracy of your model in the real world if the data in the test set looks like data in the real world. So it's also particularly important that the analyst is in the loop with clinicians and clinical IT to make sure that the data are representative, right, of real data. Finally, in another part of this AI stack, the algorithm researchers themselves, right, have the opportunity to research and change their algorithms to be robust to these types of errors. So for instance, if we did have something like explainable AI, right, perhaps the model could have indicated what it was using to classify, right, these images and point out that in fact it was not something real and corresponding to birdshot. Okay, so I'll end here with saying it's obvious why these models have such an allure. The results are extremely impressive and have the potential to transform medicine, but it is extremely important that we have conversations like this one. And I'm excited to see where the discussion goes. Thanks.
you. And I'm going to press you as after Dr. Geis speaks, because I think we have a number of generalists who are dialed in with us today. And a lot of the things you just said, I think might have gone over a few people's heads, at least with some of the messages I'm getting, because they don't have a good sense of what some of those ideas mean. But boiling it down, I'll press you a little bit to unpack for us bias, talking about what it means to look at data distributions and how to make algorithms more robust. So kind of the simplified version of this is garbage in, garbage out,
Yes.
right? But the basic idea of some of the concerns that exist with respect to data quality, and suspicions about really high accuracy rates that people claim with respect to algorithms. I think we have Dr. DRAELOS back on, and so why don't we see if her audio is working before we go to Dr. Geis and then come to Dr. Geis. So Dr. DRAELOS, how's your audio working now?
You can let me know. Does this sound okay?
Yes, it sounds terrific. So why don't you jump in? Yes.
Switch to my phone, so I apologize if it falls over. It's kind of propped up on my laptop screen. So I'll get back to the COVID and AI models for imaging. So as I was saying, the current gold standard is this RT-PCR test, but there have been several international groups and societies that have released guidelines for usage of CTs and other kinds of medical imaging in COVID in general. One of these is the Fleischner Society's multinational consensus statement, which was released recently, and they recommend that imaging is not indicated in patients suspected of having COVID and mild clinical features unless they're at risk of progression. But they do recommend imaging in circumstances where a patient has COVID and worsening respiratory status, and also in resource-constrained environments to help with triage. There's also a really nice review paper about chest CTs and COVID that was published recently in the American Journal of Genology, I can't say that word. And this one went over numerous studies that have claimed very high sensitivity or very high specificity for CT scans in COVID. And it identified several issues with these studies and their claims, drawing the conclusion that even when RT-PCR tests are negative, delayed, or unavailable, there are currently no data to support CT as a replacement test for RT-PCR because its true sensitivity is unknown and CT findings are non-specific, meaning that the types of findings which are seen in COVID can be seen in many other kinds of pneumonias, and so they do not uniquely identify COVID. With that being said, to summarize, at the moment, imaging in COVID is not recommended for diagnosis or screening, but it may be helpful for evaluating complications or performing triage in resource-constrained environments, or possibly prediction of worsening versus improvement. And this ties in with an interesting concept, which is that building a model and developing it is definitely different from deploying it. As one example, a COVID diagnosis model where you feed in a CT scan or a chest X-ray or some other kind of medical imaging and get out a COVID diagnosis could be deployed appropriately or inappropriately. An appropriate example that is in line with current medical guidelines would be to deploy such a model to assist with triage in a resource-constrained environment. And an example of something that would not be a good idea according to current medical guidelines would be to deploy such a model as a replacement test for RT-PCR. So I think that is an interesting thing to keep in mind, and fits in general with the concept that it's a good idea to have all deployment of machine learning models be in agreement with current medical best practices and under the oversight of medical professionals. I also wanted to briefly touch on, given that this is about ethics in imaging, the notion of fairness in machine learning models. There are sometimes I've heard a hope that because machine learning models are trained in computers, that they'll somehow inherently be objective or free from human issues. But in fact, because machine learning models learn from data, it's very easy for them to become biased. And there have been numerous high-profile examples of sort of embarrassing models that people have deployed that have turned out to be very biased. But the thing I want to bring up now is that there are a lot of concrete steps that can be taken to make sure that any models that are deployed are fair. And these include trying to quantify the fairness of the model, for example, using concepts like equality of opportunity or equalized odds. And in these concepts, you can actually get a number out of them to tell you, using these definitions, whether your model is fair. In equality of opportunity, this is a fairness metric that measures whether a group of people who should qualify for an opportunity or a group of patients who should be classified under a certain diagnosis or in a certain label are equally likely to do so regardless of membership in a particular group, like race or gender or another demographic characteristic. And then equalized odds is another metric that can be used, which will be satisfied if no matter whether a patient is part of a particular group, such as a demographic group, if they meet certain criteria, then they will be equally likely to get a positive label from the model. And if they don't meet these criteria, they'll be equally likely to get a negative label. So I bring this up because you can do these kinds of checks on machine learning models pretty quickly to at least get a sense for whether there's anything egregiously wrong going on. And then there's numerous techniques in the algorithm design and as well as in the data preparation that can be undertaken to make sure that the models are not going to be exhibiting human problems. So in any case, I'll hold off on my other thoughts, but I'm looking forward to this conversation today, and thank you.
Great. And Rachel, you may not have heard me say the same to Tim, but we're going to drill down in a lot of the concepts that you raised. I think we have quite a few people who are not as familiar with algorithms who are dialed in today, and particularly in its deployment with respect to COVID. And so I think some of the highlights that you provide, I'm going to just unpack with you in a few minutes after we hear from Dr. Geist to get into some of the issues with respect to the ethics. So thank you for your opening remarks, and we'll turn to Dr. Geist now.
Thanks very much. So, former Supreme Court Justice Potter Stewart described ethics as the difference between what we have a right to do versus what is right to do. And when I think of medical ethics, it's sort of a collection of balances, what's best for self versus others, or we're balancing money, fame, the ability to influence others versus what's best for patients and society. And we're also balancing what's best for the individual versus best for the society and common good. From a practical get stuff done point of view, I always think about trying to actually specifically write down two things we want to define for ethical AI and medical imaging, or even the rest of medicine. First is, what's the Goldilocks balancing point? What compromises between things like privacy or distributing benefits and harms equally are we as decision makers comfortable with? Because let's acknowledge up front that we're not saints. AI is going to cause some harm or inequalities, through data privacy loss, if nothing else. Some people are going to make money off of other people's suffering. I guess more succinctly, it's what compromises are we willing to make for the incremental gain of, in this case, hopefully better diagnosing and treating COVID. The second point is, what are the guardrails beyond which no one should be allowed to go in the effort to get control over COVID? Suppose I said I could stop COVID if each of you allowed me to see every part of your medical history, every place you've been the last 2 years, how much you drink or do drugs, or the details of your sex life. How about if I say you need to allow me to release that information to the world? So I'm curious about where we want, finding these two things, where do we want to go and where we just shouldn't go. And we might also consider the wiggle room between the two, what I call the New York Times territory, where you might not end up in court, but you do make their front page because of headlines with your evil technology. I use two different frameworks for considering radiology AI. The first is described by an ethicist named Floridi, who looks at the ethics of data, the ethics of algorithms, and the ethics of practice. And the second is a more operational approach to think about independent verification and validation That's sort of a process that was originally started to deal with complicated, high-risk things like ballistic missiles. But that's to deal with AI through its entire life cycle. And here again, I look at it in 3 parts. First, technically, does it work? Then ethically, does it do what's right to do? And finally, contextually, which in this case is, does it have a positive clinical impact? The current COVID pandemic adds wrinkles to our approach. Suddenly, society as a whole is prioritizing short-term survival. That's not something we've thought about very often in the past. Sure, we're concerned about our individual and collective long-term prognosis, but this collective focus on acute actions is way new. And it may have changed society's definitions of both the Goldilocks zone for ethical radiology AI, as well as moved the guardrail farther into the New York Times zone or beyond. In the end, these points are going to get defined by the people who control the data and build the tools. They'll be influenced by public perception to more or less extent. But after watching the tech leaders at the recent congressional hearings, I assume this public input's going to be less influential than we'd like. You know, finally, you know, I Googled Rachel and Tim, and they've got a lot of amazing stuff. And so I look forward to hearing you guys' take on a lot of these things. Thanks.
Terrific. Thank you for your opening remarks, Dr. Geis, and your helpful framing between the Goldilocks and the New York Times for us to think about these issues. I'm going to back us up for just a moment, and I'm going to play the uneducated in some ways about AI, because I am in many ways about the ways it's being deployed for COVID, and just make sure that I have it right. So when we're talking about COVID, right now, as far as the New York Times tells me and other scientific journals, there's a constellation of symptoms. And we're trying in some ways to figure out, is there a way to have early detection before somebody, or in the pre-symptomatic or asymptomatic period that somebody has COVID. We then have when somebody actually has a set of symptoms and they come in or they don't come in, and we want to do a test, and there's a nasal swab test that we can shove up your nose to figure out if you have it. And then there's a whole set of symptoms that may or may not develop, and there's just a whole lot of unknowns. Is that all fair, if everybody agrees with that, that we're kind of in, that we've got a whole bunch of things at the front end, and people are trying to figure out, is AI useful in any of this, right? And in radiology in general, people have started to use AI in at least in some areas, right? So in breast cancer and other areas where we're using a whole bunch of images to try to so-called train AI to be able to detect things, and detect things that potentially even the human eye can't see or can't see as well. Maybe earlier signs of breast cancer before a radiologist would normally be able to do so. Or if a radiologist is unavailable or unnecessary, we could use artificial intelligence that has been trained to be able to look at an image and be able to make predictions. Do I have all of that right so far? If I jump in and correct me if I've got any of this wrong. Okay, and so with COVID, given that we have a whole bunch of unknowns, Rachel, as I understand it from your remarks, right now, looking at chest scans of the lungs is not best practice for diagnosing COVID. Is that fair?
Yeah, so, and the funny thing is there've been a lot of papers that have been published on machine learning models for diagnosis of COVID. So that's a really popular thing to do right now. And the thing about these models is that the way that they're motivated in the papers could be with or against medical guidelines. I've seen some papers where they say, we built this diagnosis model for COVID, and we're hoping that maybe it could be used to help with triage in a super busy emergency department or something. And then there's other models where they bring into question, for example, the current practices of using RT-PCR tests and whatnot, and say, maybe we could just replace that with CTs.
Let me pause you there for a minute, because we already have a question from the audience about that, which is just so that people understand, when when somebody's shoving, you know, this nasal swab up your nose and down your
That's the
throat,
RT-PCR test.
but what they're doing is they're looking for some signatures, DNA signatures, is that right, of COVID? What's the PCR test? Because some people don't understand the PCR test or RT-PCR test, the amplification, any of that. So maybe you could just explain that in 30 seconds.
Sure. So the nasal swab is looking for pieces of viral RNA, so parts of the viral genome, and the test itself involves making lots and lots of copies of the sequence of the virus, and then because
and that's what takes a while, right? Is the reason that you can't get a test result immediately is that you have to make lots and lots of copies of whatever has come off of the swab to see whether or not those pieces are there.
So it actually can be done in about 20 minutes. I actually had to have a rapid COVID test at some point, and they swabbed my nose, and then maybe 15 minutes later they had the result. So the actual copying can happen very quickly, but I think the reason why it can take such a long time, several days in some places, is more just a logistical problem where you have only one machine and then you have a bajillion different tests you need to run, and you can only get so much throughput of the machine. So
okay, so the gold standard right now is that test. People are
Mhm.
looking to see if AI might help us, and looking at things like, would chest scans help us? And if you don't have those tests available, does AI prediction looking at the chest CT scans help you diagnose COVID? Like, suppose that you're somewhere where there are no tests available. Is the AI better than a physician doing a diagnostic and saying, you know what, like based on your symptoms, it seems like you probably do have COVID?
So I've seen one study where they were comparing two doctors, and I believe they compared to a senior thoracic radiologist, so someone who is an expert in chest imaging specifically and has been practicing for a long time. And then they also compared to, I believe, a fellow who would be someone who's completed their residency and then they're in the middle of some additional training. And then I think they may have also compared to a resident who was doing their radiology residency. And what they found was that their particular algorithm, which was a combination of a chest scan as well as some clinical data, was able to perform about on par in terms of the performance metrics they were looking at with the senior radiologist, and outperformed the fellow. So,
and this is for COVID in particular, or just in radiological
it was
scan?
COVID. Yeah, it was COVID
in particular.
So they took CT scans of the chest, and then they also took some clinical information like some laboratory values from a blood test and age and whatnot, and then built an algorithm to predict COVID or not. So it was just binary classification 0 or 1. And then they compared to a couple different doctors, and they found it was about on par with the senior doctor. But I think there haven't been that many I haven't heard of any cases where there are absolutely no RT-PCR tests available, but I guess hypothetically, if that test suddenly became unavailable, then a CT could be.
Well, and if it was better and more efficient, that would be great. Raim, you were about to jump in. Let me let Raim jump in.
Say, this whole deal of, AI is better than doctors. It's not that this stuff doesn't work. I mean, I can build an algorithm. There's no question that these machine learning things can extract more information from the pixel data of a medical image than 2 human eyes can.
Yep.
The kicker is that these things don't generalize. And so I build it, and we see this over and over, where I build an algorithm, I train it on my own data, the validation data set, or even if I'm using it clinically, is exactly the same. I'm using it on my one CT scanner, say. And yeah, it oftentimes is better at finding the pixel patterns that correlate to that disease. But then I take that algorithm and I put it on another CT scanner, or I send it to my friend at a different hospital, and it might work and it might not. And this is the thing that, from a practical standpoint right now, is just, this happens all the time, so it's, and in a big place like Duke, where you have hundreds of different CT scanners, I haven't talked to the guys that are doing this there, but the other places where I deal with this, it's a nightmare,
Got Got it. Now, is that
each
Tim?
CT scanner has its own fingerprint, pixel fingerprint. And, you know, maybe Tim can probably, and Rachel can talk to this better than I. There are ways to deal with this, but it's just because I have a system that works great on my sort of prototype, you know, you might even call it a toy, that I have it in my one scanner. Don't confuse that with, now I have something that's ready for production at scale in the wild.
Well, so I've got two questions for you, Raim. I want to hear from you in 1 second, Tim. Let me do a quick follow-up here because I see you want to jump in. So, Raim, suppose you're somewhere like Duke where you have lots of different CT machines. Could you train the algorithm using the results from all of the different machines? And could you then have a better model? Is it just too expensive or too?
Yeah, well, no, that's certainly, if you, that's the deal, is if you can train it on every different kind of scanner.
Yeah.
And that goes back to understanding what data you have in your training set.
That's actually what I did with a big data set I put together. It's just all the CT scanners in the hospital, but just the download time for that data set was a couple months, and then the pre-processing time was another couple months because it was so much data.
Which is difficult for COVID when we're moving as quickly as we are. But this addresses one of the issues, right, Raim, for you. You know, you're one of the authors of this important joint statement and report looking at the ethics of radiology. And as we're looking at bias and validation of data sets, it's really important for policymakers, for regulators to be looking at what is the basis of the data that it has been both tested on and validated on. Is it generalizable? Before you kind of rush to approve, it's important to understand, is it going to be useful in other contexts other than the single area in which it was trained on? Is that fair?
Absolutely.
Yeah, imagine reality where part of this regulation process was testing and perhaps even incorporating, right, a little bit of data on a new scanner, right? So, you know, not necessarily requiring that it generalize immediately to everywhere, but, you know, if you're actively monitoring the performance, right, on this different scanner and there's a potential issue, you can detect that, and you probably don't need that much more data, right, to sort of fine tune the process, right, for that new scenario. And this issue of things not transferring across sites and instruments is not a AI deep learning thing, right? So you can go back to very simple, you know, logistic regression, linear models, right? And you'll see differences across hospitals, right? Across countries, right? It's a big problem when you're going from high income countries to low middle income countries, right? Trying to get these models to transfer. And the idea is you have to basically fine tune these models, change the way they're calibrated, right? Potentially retrain them and modify them a little bit to adapt them to this new scenario. So if that's the reality and we have to do this, maybe
and Tim, do people have the appropriate expertise and knowledge to do that, right? I mean, so I think part of when you're thinking about the ethics of using different AI models, particularly if you're talking about under-resourced areas as a way to, as it's been discussed in some instances, right? I mean, so if you don't have a specialist available or you don't have a radiologist available, could you use AI instead? Mm-hmm. And if that's the case and you don't have anybody who can validate it or test it or train it or modify it or even understand it,
yeah, it's not
appropriate to deploy it in that context. And I think it's important for people to understand it may not be, right? There may be some significant, it's not as simple as simply saying, okay, we have a CT scanner and nobody who can read it, but we've got this AI machine so we can just plug it in and it's going to give you a response. And then we're going to treat you based on the response it gave you, right? We're going to assume if it says you have COVID, that you have COVID. It's scary, but this is how some people are contemplating it. And what some, I think, regulators and policymakers are imagining might be possible is to approve something like AI diagnostic, you know, algorithms, deploy it in settings where you don't have experts who are testing, validating, and interpreting it, and not necessarily providing the transparency and the explainability of what's behind it, both to the end user, but also to the regulator who's overseeing it. And so how do we bridge that gap, right? Let's assume that, Rachel, for a moment, let's assume that the algorithms actually do get to a place where they are as good as or better than potentially predicting not if you have COVID, but if you're likely to develop some of the longer term symptoms, right? One of the things we're trying to figure out with COVID is not just do you have it, but are you going to be in the population who ends up hospitalized or with, you know, cardiomyopathy or with longer term lung damage? Can we start to predict and see the differences of the different pathways people might take? And here AI might be helpful, right? If we're able to process a huge amount of the differences, if we're able to collect the data and start to find trends. If that's the case, how do we ethically enable those things to happen, Raim, to your point, if they're not generalizable, right? Maybe at this hospital, this predicts the pathway, but it's not going to be that useful in, you know, developing country X or in different country Y, or even in neighboring state Z that has a different CT scanner. Any of you jump in here?
Rachel, do you want to start?
Carefully.
I mean,
so. Go ahead.
Well, I think from a practical standpoint, companies that are building these things are going to want to try to stick with simple stuff because they, like, you know, do you have COVID or not? Because they have data, that they have labels to go with the images that most of the time radiologists are providing. If you're looking at something like predicting who's going to have, say, cardiomyopathy, some cardiac complications going forward, now your label isn't going to be the radiology report. It's going to be following the patient clinically. Now so it'll be somewhere in the EHR, and it's going to be at a time later than what you have right now to find the ground truth. This is a difficult thing.
I think it may continue, Raim. I'm not that optimistic that we're looking at an end to this anytime soon. So it may be that later is still going to be useful.
So people like to do things right at the moment, at least, that are where they can get easy labels. You know, and I kind of going back to what both Tim and Rachel have said is that, you know, I work with some of the students at Carnegie Mellon, and the PhD computer science students there often joke that, you know, it takes them 5 years to get their PhD. The first month or two is building their algorithm, and the rest of their 5 years is figuring out the data and the data structures. And I think that's, we don't give enough credence to how difficult it is to try to figure out the issues with the data right now to make these things work. I mean, right at the moment, I think we're in what I call a prototype era, where we're building things almost more to learn, you know, how to do this. But because there's a business case involved and the thought that maybe you can make a lot of money doing this, that's getting scrambled into this right at the moment. And so people are trying to, you know, in my estimation, oftentimes make money off of things that are not as robust as they should be. So,
do you guys have any, I mean, the three of you have any worries based on the current state of where we are? I often hear, you know, kind of anecdotally, as people are going into medical school, you know, you shouldn't go into radiology because there will be no more radiologists. AI is going to replace all of radiology. You know, already, you know, there's going to be a substantial reduction in skilling, de-skilling of radiologists because they're going to rely on, you know, AI rather than being able to actually interpret a scan for themselves. And if you look at, you know, Raim, as you've said, you know, at a kind of pixel level, AI is going to be better than the human eyes at being able to pick out, you know, kind of very small and fine-tuned differences. You know, the earliest signs of breast cancer, the earliest signs of, you know, kind of other kinds of cancer. Like, you know, is this a realistic concern on the horizon that we're not going to have, you know, kind of trained radiologists, or that it's going to be de-skilling? You might have a technician who, you know, kind of validates what the AI says, but there won't be a need for that specialty anymore because AI will replace that specialty.
I read an interesting opinion piece on this issue that I believe was written by a radiologist in California. I can't remember his name at the moment, but I thought it was an interesting, at least it was an interesting opinion piece to read, because he was saying that, at least it was his personal belief, that perhaps the number of radiologists needed would go down, but maybe the job description would somewhat change. So you could have a radiologist who is an expert in and very skilled, and they sort of oversee some automated approaches to doing some image interpretation. So it was at least his opinion that perhaps the total number of radiologists might decrease, but there would still be radiologists there to, you know, keep an eye on everything and also deal with really weird, unexpected things, because that's something that machine learning is currently really bad at, is dealing with the unexpected, and humans are still much better at that in general than machines are. So I don't think it's realistic to assume that the entire field of radiology is going to become automated, because there's just too much, there's too many issues with the current models for that to be automated safely.
You say current, Rachel, right? So what about in the future, 5-10 years from now? Right?
I think about this, which is if you were
give us some
advising if you were advising somebody going into medical school, would you advise them against going into radiology and say, like, that's probably not your most promising specialty because technology is probably going to eclipse the specialty?
I get asked this question all the time.
I'm sure you do. Yeah.
And the answer is no. I mean, radiology from the very beginning with x-rays is a combination of technology and humans trying to figure out what's going on inside the body.
Mm-hmm.
This is another tool to do that. A couple of things. One, the more you learn about machine learning, just like anything else, I mean, the more you learn about it, the more difficult you realize it is. But I think it's going to get more interesting, going back to your point about, you know, can I not only use technology to figure out, does somebody have COVID or not, but can I use it to predict some things that I haven't been able to do in the past?
Right.
And I think a lot of the just fascinating stuff in radiology right at the moment is going to be, okay, I've got this tool that can extract a whole bunch more information out of the pixel data of a patient's insides. What can I do with that extra information that I can get? I can do just, and I think I can do a whole lot more than I'm doing right now. COVID's an interesting example. So we can say, oh, I can look at the infiltrates, the sort of white places on the CT scan or the chest x-ray that might indicate that a patient has COVID pneumonia or, you know, inflammation due to COVID. But there are also these complications from COVID, like microemboli, little blood clots out in the periphery of the lung. Those are hard to diagnose, and especially like right now in patients with COVID, you don't want to do usually some of the traditional tests that we do to look for those blood clots. Can I use AI to try to figure that out? Yeah, but they're going to have to be humans in that loop for a variety of reasons. I mean, we haven't talked about a lot of the other complications. We talked about data set shift, but there's just a whole bunch more. We're going to need different skills. If you just want to sit in a dark room and
read
look
scans,
at
that's
the
probably
pictures,
not you anymore. Yeah.
No, you might not want to go into radiology, but in terms of the fascinating stuff, it is going to be so cool. And we don't talk about how robots or AI are going to affect other specialties, but, you know, I mean, I think I'd probably be more scared about being a surgeon.
Right.
Than I would be about being a radiologist right now.
Yeah. Well, I mean, you raised some interesting points here. One of them is thinking about, okay, so maybe there's these little emboli or other things on the scans, but presumably there's also some other data from patients that will help us predict their outcomes. I mean, we already know that there are differences socioeconomically. There may be differences by blood type, although I think that's, you know, kind of up in the air as to whether or not that actually means anything. there may be genetic differences and genetic susceptibility differences. Presumably there's a lot.
Medical
And
history, yeah.
medical history, I mean, there's a whole bunch of things that may be useful. And I assume that despite what Rachel said about it taking months to download this entire like enormous data set, and we'll get into like how are we going to validate if it takes that long and need that much computing and processing. But presumably the more data that we could get about patients and put into these sets, the better the models will ultimately be if what we're trying to do is something with prediction, right? It'll start to see trends that we don't necessarily see. And as we think about that, as we think about pulling a huge amount of information from electronic health records or from patients themselves, or other kind of information, like all of these apps that are being developed for tracking symptoms and tracking information and tracking who you're in contact with, et cetera. Do you all have concerns about how that data is used, consented to by patients, stored, shared? What are the risks to individuals and to society of the collection and use of this data? And I know this is some of the things that you address, Raim, and the group of people that you wrote the Ethics of Artificial Intelligence Radiology, the summary of the Joint European and North American Multi-Society Statement, gets to some of these issues. But I'm wondering if you all, I know Raim has, if you guys have thought about this issue of how do we ethically do this, gather these huge data sets without posing a risk to the individuals whose data is being used to do so?
Well, I could go on all day, but Tim, I know that you've got some interesting things, and Rachel, you talked about this already. Why don't you guys?
Why don't you each hit on it? Because I think we've got about 7 minutes left. We have one more question. Some of these are questions that I'm bringing in from audience members. By the way, if you are watching, continue to send your questions to Tim McDermott or to Ben Shepard, who's fielding them to me. But Raim, since you're part, since you're lead on this summary statement, why don't you kick us off, and then we'll turn to Tim and Rachel to comment on this issue as well, because Rachel already was commenting both on the collection of the data, the huge data sets that she's pulling, but also some of the privacy concerns. And I know Tim has thought about this from data use and collection and storage. So why don't we start with you, Raim?
In summary, no data that you release are going to be anonymous. It's just a matter of how expensive they are to re-identify for a variety of technical reasons. And those data are going, if you release data, it's fair to say that those data are going to get used in ways that you didn't anticipate. So this is a real problem that we see in doing that. One of the practical solutions that we're doing in radiology is, instead of releasing the data to the algorithm, sending the data to the algorithms, like letting data outside of Duke's firewall and giving it to a company to do something, we say, okay, you bring your algorithm inside my firewall, bring the algorithm to the data, and we'll run it inside, but we're not going to let you actually see the data. Even then, you probably have to do some things to your data to keep the quasi-identifiers small. The American College of Radiology is building a thing called AI Lab, where we'll actually do that for just about every imaging site in the United States, because we already have those pipes for accreditation. And so I think that's one way to keep the data private. But I'm very concerned about this. That sort of 360 view of patients from all the different kinds of data. Anybody who does that right now would love to be able to add medical data to that 360 view. And we see this right now with people reusing the data and reselling it once it gets out there. Mm-hmm.
It's interesting that the AI lab sounds like an interesting model. I know a number of different kind of industries are thinking about a federated data model, or having some sort of entity, which might be an entity that safeguards the data and firewalls the data. People can come in and query it, but the data doesn't leave. But I think this suggests we need a data solution, right? Before simply continuing the process of researching without having a clear idea of how do you consent the patients, how do you firewall the data, how do you deal with attacks against the data, and how do you think about the 360 view, what the implications are for invasiveness to the individual. Tim, I see you're nodding, and I assume you have some thoughts on this issue
I have
as
an
well.
additional point, which is one thing that's been frustrating over the past few years as these methods have been taking off in medicine, is that unlike other machine learning data that is typically released with the paper, right, with the code, right, so that people who are interested in rigorous validation and reproducibility can go in and find the data and run the code, right, to double check all of these results. And to not have that option for most medical data sets can be not only frustrating, right, but also potentially damaging, I think, to the entire enterprise. And so finding a solution in which that's somehow possible, right, in some way behind these firewalls, right, I think is important, right? So not just training and storing, but also providing access to others, right?
Right. Yeah. I mean, so
I would
we
actually
both have to
also-
safeguard the data, but we also need to find ways for people to be able to validate and review the data, but but potentially behind firewalls. Rachel, please, I cut you off.
Oh, it's all good. I would actually also argue for sharing data openly whenever possible. So there are lots of different, even for medical images, there are lots of different data formats, and they come with different potential risks. So for example, if you share imaging data in DICOM format, then anonymization can be really tricky because you have to account for all these metadata fields that can include protected health information. Whereas if you share the same data just as, say, an array of the voxel data, then at least you've eliminated the risk of accidentally sharing information through the metadata. And at that point, the concern would be, would you be able to identify someone and do something malicious on the basis of their chest image? Could you, from just that image alone, could you identify the person, or with something burned into the image? But that becomes a lower risk than, say, releasing the DICOM. And I think one advantage to sharing data openly, when it's feasible to do so in a way that protects privacy as much as possible, is that it gives a lot of people the opportunity to work on the data set, and as they work on the data set, they can identify any problems with it, or they can kind of collectively work on getting better models on the data. So there are some advantages to being more open, and it can solve some problems to allow more eyes on the data set.
I think these are really good, kind of points and counterpoints, right? Which is, good science is responsible science. Responsible science requires that you be able to validate the data and validate results. And the only way you can do that really is by having some form of transparency, explainability, understandability, and access to the data to be able to do so. So trying to find ways that balance those sound like they're really important. We have just about 30 seconds left here. I want to, but first, thank you all for this really enlightening discussion. There's so much more for us to dive into, but I was hoping we might just take a few seconds from each of you for you to tell me kind of most optimistically, what would you say in 2 sentences or less is the role of AI in radiology for getting us through the pandemic? And so Rachel, why don't we start with you?
I would say that the role of AI in radiology for helping us get through the pandemic is as something which has the potential to help with perhaps predicting future outcomes or triage. And it's a tool that maybe could alleviate some burden on clinicians if it's designed very carefully with clinical application in mind.
Great. Tim.
Yeah, I think something that's in reach, and this is related to triage, there is this scenario in which we have no tests, right? And then you want to try to use a chest X-ray as a test, and that's probably not feasible, right? But there's also another situation we seem to be in now, which is maybe a limited supply of tests, right? And so can we use the performance, which might not be perfect, but could be perfect on edges, right? Like the model is 100% sure this person doesn't have it, or 100% sure they do, right? And it's this middle, right, of your calibrated model that you're using to assign these resources, which might be scarce.
Thanks. Sense. Reem.
Well, I think, going back to that, if we say that we're in the prototype era for these things right at the moment, I'm leery of saying, oh, let's put one out in the wild and say we're going to use it, at scale to do something. I think it's more a deal that we're going to put them out there to learn things, but I wouldn't confuse that with saying, we just shouldn't advertise these as being a solution right at the moment.
Yeah, that makes sense. Well, so maybe one of the ways it
place
helps
where
us
we're
through the
gonna learn
pandemic
a
is that we learn a
lot.
lot, which will hopefully prevent the next pandemic. All right, with that note, I want to say thank you. There's so much more for us to discuss. I would encourage, even post this conversation, for people to share their thoughts and comments with our panelists. Thank you for joining us again. Please tune in for our next coronavirus conversation and go to scienceandsociety@duke.edu in order to learn more about both our offerings and future sessions. Thank you all and have a good afternoon.
Thanks, NITA. Bye, everyone.
Thanks very much.